Welcome you all. Today I will discuss about maxillofacial injuries, particularly mandible, maxilla, and soft tissues. Face is a cosmetic region. Injuries to face may lead to unpleasant cosmetic effect. What are the types of injuries? Contusion, abrasion, foreign bodies, tattoo, and contamination. Also, puncture wounds and penetrating injuries, lacerations, burns, and chemical damage. All these leads to unpleasant scar formation and also ugly look. So always it's mandatory to suture in the right way to avoid maximum scar formation. The specialized tissues like forehead, eyelids, ears, nose and lips gives more cosmetic effects, especially in injuries to eyelid. The tears are secreted from lacrimal gland and which passes across the cornea, enters into the canaliculi and opens through puncta and drains into nasolacrimal sac, which forms a nasolacrimal duct, which um, drains into inferior meatus. Any discrepancies, either the fault in suturing, may lead to epiphora. The same way, lips is a cosmetic region. There's a white line and a red roll. White line has to be coincided while suturing, otherwise that will look like a cleft lip like appearance. So that will look ugly. So let's come to mandible fractures. Mandible, usually the sides like condyle, tooth bearing area, canine region, symphysis, and ramus, and coronoid, and all these are the usual sites of fractures. This is a fracture definition. You can take it from any other standard textbook, no problem. This is mainly classified into favorable and unfavorable type of fractures. What is favorable? Favorable means the muscle pull will tend to keep the fracture segments reduced. But in unfavorable type of fracture, muscle pull will tend to distract the segments. I'll explain. See, this is lateral, this is medial. Laterally more posterior, medially more anterior. The fracture segment separates because of medial pterygoid and lateral pterygoid muscles. So we say vertically unfavorable type of fractures. See here, vertically favorable type of fracture. Here you can explain it as laterally more anterior, medially more posterior. On the side, this side. The same way, horizontally favorable fracture. This is superior, inferior. Superiorly more anterior, inferiorly more anterior, superiorly more posterior. This masseter and medial pterygoid tend to reduce the fracture segments. We say horizontally favorable type of fractures. Here it separates, say horizontally unfavorable type of fractures. Kruger and Shilly, he classified like symphysis, canine, body, and angle, ramus, coronoid, condyle. Condyle is having extracapsular or intracapsular fractures. What are the clinical features? Swelling and bruising, intraoral hemorrhage, step in occlusion, trismus, Mendel nerve anesthesia, loosened teeth. In intraoral examination or extraoral examination after trauma, you can examine this. All swelling will have, sorry, all fractures will have swelling. This is a step deformity. Intraoral examination, you can see there's a step deformity. Once it is fractured, this segment is unfavorable type of fracture. So because of the masseter and lateral pterygoid, sorry, medial pterygoid, this segment separates. We say it's a horizontally unfavorable type of fracture. So there will be a step deformity here. This is a loosened teeth. A loosened teeth will be present in fractures. This is sublingual hematoma, bleeding from external acoustic meatus. And this is Mendel nerve paresthesia. That means This inferior nerve enters into the mandible through mandibular foramen and exits through mental foramen. Any fracture at this point lead to mental nerve paresthesia. This is again trismus, inability to open the mouth. You say it's a trismus. So what are the what are the how can you do the how will you diagnose? Diagnosis through clinical features and radiography. This is OPG, orthopendomograph. OPG, orthopendomograph. Lateral oblique left, lateral oblique right. This is PA, posterior view of PA skull can be taken to view any fractures present in the condyle region or in the body of. This is the ugly duckling stage where the patient is at 7 to 14 years of age. Both erupting tooth buds are also present. So with the permanent dentition, the teeth usually erupts from the lower border of mandible. So in any case of fracture in uh, pediatric mandible, always go for a conservative type of management, not to damage the erupting tooth buds. This is transpharyngeal view to view the condylar fracture. This is OPG again can be taken for viewing condyle. See, this is a fracture line here. So this is an occlusal view. See, this fracture can be visible like this. It's an occlusal view. In some centers, they won't have CT. So what we do? We can take an occipitomental 10-degree projection X-rays. You can see these lines. First four lines are called Campbell's line, and the fifth line is called Trapnell's line. Any direct or indirect radiographic features associated with fracture can be diagnosed as a it can be easily diagnosed. What are the direct radiographic signs of fracture? There is a separation sign, an overlapping, sutural diastasis, abnormal linear density, disappearing fragment, or a step deformity, or widening of periodontal ligament. Indirect radiographic features like soft tissue swelling, paranasal sinus opacification due to collection of blood, air in soft tissue, air in orbit, we say pneumo-orbit, intracranial air and trap, and we call it pneumocephalus, or if it is present in spine, we call it pneumorachis. And also, the dental injuries can also be seen in these X-rays. What are the types of fractures? Simple, compound, comminuted, green stick, and pathological. Displacement of fragments depends on the pull of attached muscles. Here, the temporalis, here the masseter here. Medial to that is medial pterygoid. This is geniohyoid and anterior of digastric. All these muscle will have exert pull on the fracture segments. And also angulation and direction of the fracture line, integrity of periosteum, extent of comminution. Treatment is mainly reduction, fixation, immobilization, and rehabilitation. If it is a hairline fracture, no need of treatment. If it's a dentate patient, we can use many methods like interdental eyelet wiring, Mendel arch bars, metal arch bars, silver cap splints, edentulous. In edentulous patients, we can modify the dentures or gunning type of splint. Other treatments like supplementary fixation, plating, this intraosseous wiring, upper border wiring, cortical, we'll come to that. This is interdental eyelet wiring. These are the small eyelets can be used fixed both upper and lower arch together. This is called intermaxillary fixation. Intermaxillary fixation, both upper and lower arch in a reduced position. We usually keep this intermaxillary fixation for 4 to 6 weeks of time. So this X-ray OPG shows that the bilateral body of the mandible is fractured. We can keep it in occlusion, and the ultimate treatment will be like this. Once after reduction, the bone segment will come to in normal anatomical position. These are called metal arch bars, a rich pattern arch bar. This is modified arch bars. Again, the ultimate aim is to get both upper and lower arch together in a reduced position. These are the cap splints. The teeth are present, so the teeth can be used to attach the metal caps, and both upper and lower arch can be placed together. Okay, these are the dentures. If the patient is edentulous, that means no teeth, no teeth. If no teeth, either the existing denture can be modified like this, or you can make a splint like this. Is called gunning type of splint. This is upper border wiring. Usually the duration of fixation, I said intermaxillary fixation, depending on the age. 0 to 7, maybe 3 to 4 weeks of time. Above 65, it is 5 to 6 weeks. All these are the complications usually associated with fractures. Here, there's a fracture. It's not a proper way of treatment. It's not healed completely. What are the complications? There's a loose tooth, loss of teeth, delay of union, malunion, non-union, late onset of trismus, persisting mental nerve anesthesia. Complications of condylar fractures. Usually there'll be trismus, osteoarthritis, subluxation, late onset of trismus, deviation to attached to side, ankylosis and asymmetry, open bite, neurological auriculotemporal syndrome, mandibular anesthesia, aneurysms and on. See here, this is tooth, a tooth at the line of fracture. Usually the tooth become non-vital and there will be periapical pathology. And if this is confined to bone, we say it is osteomyelitis. Sometimes it extends to the periosteum, and if it is break in the periosteum and it comes to the soft tissue, we call it as a cellulitis. See, this is cellulitis after trauma. These are the external fixators. It's seldom used nowadays. These are the complication again. This is a exposure of plate exposure here. Open bite. These are the atrophic mandible, especially in case of edentulous patients. Usually the mandible become very thin. So what we can do is to take a piece of rib and split it and graft sandwich between the the segment can be sandwiched between the fractured rib, split rib can be placed like this. Ultimately, you get these are the areas of fixation. This is Champy's osteosynthetic line. These are the type of fixation. It's a wrong method. If it's a body of the mandible, only one plate is required. Again, here is a segment is lost here. All these are the complications. See, loose screw. See here. These are the reconstruction plate to reduce the segment, and you can fix it using this reconstruction plate. All these are the complications associated with mandible fixation. This is a fracture line here. See here, it's a fracture. So uh, that's mandible fractures. Now let's come to maxillary fractures. In maxillary fractures, René Lefort was the first person he classified it. If it's a low velocity force, it's usually associated with Lefort 1 only for two, only for three type of fractures. If it's a high velocity force, not just one, two, three, rather, there will be naso-orbital ethmoidal complex. Sometimes there will be cervical spine injury. So these are the surgical anatomy of this. This is zygomatic bone. This is maxilla. This is dental component, dento-alveolus, alveolar component, dento-alveolar. And this is maxilla. This is dento-alveolus. This is dento-alveolar. Maxilla. This is palatine bone, lateral wall of nose. This is septum. This is nasal bone. Usually in maxilla, it consists of areas of weakness, like all the sutures, frontozygomatic, zygomatico-maxillary, zygomatico-sphenoid, nasofrontal, maxillofrontal, nasomaxillary, mid-palatine. All these sutures are weak structures, and also neuroscalar bundle as well as maxillary sinus. And there are areas of strength like vertical pillars and horizontal pillars. Vertical pillars, zygomatic buttress, piriform aperture, pterygomaxillary junctions. Horizontal pillars, supraorbital rim, infraorbital rim, alveolar process of maxilla. If it's an Leaford 1 type of fracture, the other name for this is Guerin type of fracture. Guerin. The fracture results from a force delivered above the level of teeth. The cause of fracture from lateral border of piriform sinus across pterygoid junction, separating nasal septum, nasal cartilage, maxilla move posterior and inferior position, lead to open bite. These are called Leaford 2 type of fracture. The other name for this is pyramidal type of fracture. It looks like a pyramid. You say pyramidal type of fracture. Usually the force delivered at the level of nose. The fracture line occurs at the nasofrontal suture through lacrimal bone across infraorbital rim and the region of zygomatico-maxillary suture. A complete course lateral wall of antrum at the junction of pterygoid plate. This is Leaford 3 type of fracture. Craniofacial disjunction. This is frontal, zygomatic, nasal. Again, this is frontal bone. This is maxillary bone. This is maxillary bone. And this is separated. The whole midface is separated from cranium. Here, the force is delivered at the level of orbit. It's called craniofacial disjunction. The fracture goes through zygomatico-temporal, zygomatico-frontal, along the lateral wall of orbit, through inferior orbital fissure, medially to nasofrontal suture, ends in the pterygomaxillary fissure. This is pterygoid bone. Pterygoid bone. Leaford 1 enzia, Leaford 2 either separating the pterygomaxillary fissure or sometimes there will be fracture of pterygoid plates itself. This is Leaford 3 where the midface is separated from cranium. Marziani in 1993 explained Leaford 1 low maxillary fracture, 1A low maxillary fracture with multiple segments, 2 is pyramidal fracture, 2A pyramidal plus nasal bone fracture. I told you if it's a polytrauma, there will be involvement of nasal bone, naso-orbital ethmoidal complex. So he included this. So 2A pyramidal plus nasal, 2B pyramidal plus naso-orbital ethmoidal complex fracture. Leaford 3 is craniofacial disjunction, 3A craniofacial disjunction plus nasal bone fracture, 3B craniofacial disjunction plus naso-orbital ethmoid. He added Leaford 4, Leaford 2 or 3 with cranial base involvement. Leaford 4A is 2 or 3 plus supraorbital rim involvement. What are the clinical features? It will be displaced maxilla, pain and mobility, anterior open bite, maxillary vestibular ecchymosis, and there will be air emphysema. In Leaford 2 type of fracture, nasal bridge will be fractured. In a orbital ethmoidal complex, maybe fracture may be present. There will be periorbital edema, subconjunctival hemorrhage. Sometimes there will be a restriction of movement of globe lead to diplopia and anterior open bite. Lifo 3 type of fracture. Looks like classic dish face appearance. Bilateral periorbital edema ecchymosis lead to football face, raccoon or you can say raccoon's face, panda eye. This is called bilateral periorbital edema. It looks like panda eye, and there will be CSF rhinorrhea, otorrhea, battle sign, hemotympanum, and enophthalmos. Diagnosis is made through history, force involved, the extent of facial injuries, associated injuries, and all that. And you can also take photograph, medical history, detailed craniofacial examination is required for laceration, incised wound and abrasion, contusion, if this present. And also examine the seventh cranial level. CSF leak, bone contour, step deformity, mobility, eyes is sent for fundoscopy, ears, any blood in the tympanic membrane, any perforations in external acoustic tear. This is usually you can use to diagnose the fracture segments can be mobilized. The movement of fracture segments can be detected. You can do like this, either LIFO 2 or LIFO 3 type of fractures. So always an intraoral and extraoral examination is required to diagnose a fracture. Investigations mainly through radiograph, CT, multiplanar reconstruction or MRI. Waters view. These are the CT. Here you can see there is a orbital floor fracture. This is hemosinus. This is called teardrop sign. That means the orbital fat is hanging into the maxillary antrum. Along with this is hemosinus, blood collected. This is tear, teardrop sign. Okay. This is multiplanar reconstruction of CT. And also assess if there is any skull base involvement, brain injury, intracranial hemorrhage, or frontal sinus hemorrhage. Angiography has to be performed in case of any penetrating neck injuries. Traumatic corticocavernous fistula has to be managed with embolization. Full dental assessment is mandatory before treatment. What are the type of treatment? Unilateral treatment is usually by close reduction like arch bars, ligate to non-fracture segment, intermaxillary fixation, open reduction and internal fixation, or occlusal splint, which I already explained. These are the arch bars, Jellenko, Krups, Erich pattern arch bar. These are the Erich pattern arch bar. I already explained this. Wisdom and Schuchard. Leaford 1, Leaford type 1 fracture. This requires early reduction and immobilization. Usually we can use either Rose forceps, intraosseous wiring, or a 4-point fixation is required to fix. External fixators like plaster of Paris, cranial pin, halo. The point of fixation may be at piriform fossa, zygomatic arch, infralateral or supraorbital rims. Internal and rigid fixation. Usually it depends on the plate design. Either you can use many shape plates. I'll show you. Mini plates, usually the thickness between 0.6 to 1 millimeter. Microplate, the thickness may be 0.5 to 0.6 millimeter, or the mesh or three-dimensional designs. See the plate configuration like X, H, L, T shape plate. Either stainless steel or titanium or Vitalium plate can be used. or 3D plating system, and also resorbable plates and screws. Usually, treatment like circumzygomatic wiring using an awl, zygomatic or buttress wiring, infraorbital rim wiring, zygomatic or frontal wiring, piriform aperture wiring, nasal spine wiring. These are the other methods. See, these are the mini plates can be fixed in Leaford 1 type of fracture. So these are the arch bar to keep both upper and lower arch together in occlusion. That means in reduced position. Once we get the proper reduction, you can fix it using these mini plates. Treatment for Leaford 2. Usually Ross disimbaction forceps used to reduce the fracture segments. Intermaxillary fixation is for 4 weeks, and open reduction, internal fixation also can be done. 4-point rigid fixation is mandatory in case of Leaford 2. So these are the forceps used to keep the fracture segments in position. These are raw disimbaction forceps. Apply traction has to be done in a forward direction like that, because in case of maxillary fracture, the muscle pull will move the fracture segment inferior and posterior. So to counteract, these forceps can be used to keep it in reduced position and fix. What are the surgical access to midface? Maxillary vestibular incision. The extent may be from zygomatic buttress to other. Lower eyelid incision, subciliary, infraorbital, transconjunctival, or coronal midface degloving incisions. What are the complications? Usually there will be cranial nerve injuries, secondary nasal deformities, malocclusion, and facial asymmetry. All these are the complications. Infraorbital neuroparesthesia, anophthalmos, infection, exposed hardware, deviated septum, nasal obstruction, altered vision, non-union, malunion or malocclusion, epiphora, foreign body reactions, scarring, sinusitis. That's all.